Okay, so the next presentation is this selected abstract in the cardiovascular field. It'll be given by Dr. Marc Dweck. Marc is a British Heart Foundation clinical fellow at the Centre for Cardiovascular Science in Edinburgh in the UK, and he's joining us here at Mount Sinai for a year as a fellow. His talk is entitled Systemic Atherosclerotic Inflammation Following Acute Myocardial Infarction. MI begets MI. Thanks, Marc.
Okay, so firstly, thank you very much for the opportunity to speak at this fantastic day, and I'll try and live up to the other speakers we've already heard. So we've heard a bit about myocardial infarction, and we all know that it's the commonest cause of death in the world, and certainly in the Western world. And treatments have improved, particularly in the setting of acute ST elevation myocardial infarction, where primary PCI is a very good treatment strategy. But despite that, recurrent myocardial infarction is common. And we see a lot of our patients coming back to the cath lab, back to the hospital with repeat events shortly following their index event. Up to 20% of patients in a recent study, a real-world study in Edinburgh. And the question is, why does that happen? What's the mechanism for that happening? And we know that the majority of these events aren't related to the stent that was put in as the original treatment. So a paper came out in Nature a few years ago that kind of gave us a potential mechanism for that. They looked at a mouse model where they induced myocardial infarction by tying off the LAD. And essentially what they showed was that resulted in macrophages not only moving to the myocardium to try and heal up the myocardium, but also to remote atherosclerotic plaque. And in going to those remote plaques, the theory is that it destabilizes the plaque and potentially precipitates recurrent myocardial infarction. So they proposed this mechanism where essentially the release of the macrophages and monocytes is mediated by the sympathetic nervous system, and that the destabilization of remote plaques results in repeat MI. The question really that we're trying to address in this study is whether that occurs in humans. So our hypothesis was that myocardial infarction will accelerate remote atherosclerosis plaque inflammation, and we looked to measure that using 18F-FDG. And secondly, we hypothesized that larger infarcts will cause higher increases in inflammation in these remote plaques, and also that will translate into an increased incidence of recurrent MI when we looked at real-life patients. So we selected two cohorts of patients. We had an imaging cohort that included 40 patients who'd had a myocardial infarction and 40 patients with stable angina. And each of these patients underwent FDG PET imaging of their aorta and heart. And secondly, we looked at an outcome cohort. So we made use of the GRACE registry, the Edinburgh cohort of that, and looked at 1,000 patients. And we looked in those patients to see whether the larger infarcts were more likely to have early recurrent MI, that is, within the first 30 days. So this is the imaging cohort to begin with. And what we observed was that in terms of plaque burden, the plaque burden was actually tended to be higher in the patients with stable angina rather than the myocardial infarction patients. But what you noticed for the FDG activity was that the reverse was true. So inflammation was higher in the patients post-myocardial infarction despite them having a lesser atherosclerotic burden. And that was true of the aorta of the whole, but also true for each of the different regions of the aorta. Of note, there was no difference in the signal in the paraspinal muscle, so it appears to be a specific effect within the vasculature. Secondly, we noticed that patients who'd had larger infarcts, the big ST elevation myocardial infarctions, had higher FDG uptake in their aortas than patients with the smaller infarcts and patients, again, with stable angina. And there was a moderate correlation between the FDG activity and the size of the infarct as measured using the peak troponin concentration. So what about the follow-up cohort? Well, in our 1,000 patients from the GRACE registry, we basically split them up into 3 groups. So big infarcts, medium-sized infarcts, and small infarcts, using their troponin as the arbitrator of how big the infarct was. And we ended up with 3 groups with roughly 300 patients in each of the groups. And what we saw was that the larger your infarct, the more likely you were to have an early recurrent myocardial infarction. So here's the Kaplan-Meier curve. This is patients with the largest infarcts compared to patients with the smallest infarcts, and the recurrent MI rate was higher. If you had the biggest infarct, then that was a predictor of early recurrent myocardial infarction on univariate analysis. And when we moved it to multivariate analysis, then it remained a independent predictor of early recurrent MI alongside your KILLIP score. We also looked at late recurrent MI, so MI after 30 days, and in that instance, the size of your infarct was not a predictor, and instead, more classical predictors like age, previous MI, and whether you had a previous bypass were the predictors of late recurrent myocardial infarction. So we think that this data is consistent with the hypothesis that myocardial infarction results in increased inflammation of remote atherosclerotic plaques, and that might be the mechanism by which we see early recurrent MI, and in particular the higher rates in patients with larger infarcts. And so we think that our data supports the hypothesis that MI begets myocardial infarction. However, there is the reverse hypothesis, and that is that inflammation precedes the myocardial infarction rather than the myocardial infarction preceding the inflammation. And that is a pretty tricky thing to try and resolve in human studies, because ideally what you want is a scan before the infarct and a scan after the infarct. But predicting myocardial infarction is extremely challenging, and we're never going to really do that. However, there is one potential model where we can predictably know when someone is going to have an infarct, and that is in patients with hypertrophic cardiomyopathy who have left ventricular outflow tract obstruction. So this is such a patient. He has a thickened left ventricular septum, and that is causing hemodynamic effects that result in obstruction of the passage of blood out of the heart. And these patients present with syncope. And one potential treatment that is commonly used is to induce a myocardial infarction in the area of hypertrophy. So you put a catheter down one of the septal vessels that subtends that area of hypertrophy, and you inject alcohol down it to induce a myocardial infarction, and then your left ventricular outflow tract obstruction disappears. And so our plan is to make use of that model to try and work out this question of whether the inflammation precedes the infarct or vice versa. And we're going to make use of PET MRI to do that. The primary advantage of PET MRI versus PET CT is the much lower radiation doses. And so that means that we can not only image before and after, but potentially multiple time points afterwards to try and get a picture of how inflammation changes following myocardial infarction in atheroma and the kind of pattern with which it does so. And so this study is starting just over the next couple of weeks here at Mount Sinai, where we will be doing PET MRI FDG following septal ablation. I'd like to thank the people both in Edinburgh and in Mount Sinai. It's a great pleasure to be here for the year, and thank you for the invitation to talk here. Thank you very much.
Thanks very much, Mark. Small token for taking part today. Thank you very much.
Great, thank you.
Any questions for Mark? Maybe I'll start with one. So obviously the inflammation is, although the PET scanning showing the inflammation is really important with understanding what's going on with MI. Have you noticed any, or what are your thoughts on variability within the patients you looked at? Could it be used to actually make a clinical prediction of risk for MI subjects?
Well, you could measure the FDG to predict the risk of recurrent MI, or you could just look at how big the MI is, because it correlates fairly nicely. And I guess I'm not sure this is a particular clinical value other than just elucidating the mechanism. I think what it does do is it puts inflammation up there as a target for therapy. And so particularly in patients with large infarcts, we're worried about recurrent MI. In patients whose ventricle has already taken a big hit, then maybe we should be trying harder to reduce inflammation in the remote plaque.
Any other questions?
Great. Okay. So, Matthias, yeah, please, you have time.
So traditionally, it kind of has been unclear what will be the killer application for PET-MR. I mean, there are many things that we can think of, but it seems to me this might be the thing. What do you think?
I'm biased, but I think so. I think today I've been doing work with PET-CT, and I think we are developing new tracers that are telling us interesting things about cardiac pathophysiology. The limitation is that the radiation doses associated with PET-CT are high. At best, we're going to get a chance to image at 2 time points, and the worry is that those radiation doses are going to limit the clinical utility of that approach. The predominant advantage of PET-MR is that the radiation doses are much lower, so suddenly that it becomes feasible in terms of clinical scanning and also scanning at multiple time points. But also, I was fascinated to hear your talk that the other problem with PET imaging of the coronary arteries is motion. And at the moment, our strategy is just to gate the PET data and get rid of 3/4 of it. But with MR, then suddenly we can track the motion, we can correct not only the MR data, but the PET data. And then, we're really getting into powerful multimodality molecular imaging in the heart, and I think that's very exciting.
See, our competition for coronary imaging has been CT. We've been fighting that for 18 plus years since we started at the same time, I know that, or more, right? Now when you look at it in the context of PET-CT versus PET-MR, suddenly PET-MR is looking better than PET-CT because we can deal with the issue of motion. So it opens up a different I think, opportunity for that. Yeah.